In the last decade, there have been major changes in the approach for the diagnosis and treatment of pneumonia. In particular, with the availability of new tools for diagnosis, I think the entire landscape for pneumonia has changed. Additionally, new drugs have come to market and have been approved for the treatment of this disease. So, this is a big syndrome that we find in practice almost every day. And today, we're going to discuss the approach to the management of pneumonia with a person who has spent most of his career, most of his life, uh, working on this topic. And I'm very glad to have him here. Welcome to Editors in Conversations. The objective of this podcast today is to discuss the definitions and nomenclature of pneumonia throughout the years and some of the background history of what's happening there. Elaborate on changes in the diagnosis of pneumonia, and particularly review important therapeutic changes and alterations, and have a little bit of futuristic approach thanks to my distinguished guest that we have here and his expertise. This episode is brought to you by the Antimicrobial Agents and Chemotherapy Journal, available at asm.org/AAC. I'm your host, Cesar Arias. I'm the editor in chief of Antimicrobial Agents and Chemotherapy, which is published by the American Society for Microbiology. If you plan to publish in AAC as a member, you'll receive up to 50% off in publishing fees. And as you should be aware, now ASM has an open access policy, which makes even publishing in ASM journal more accessible with high quality science. Don't forget to check our latest issue with phenomenal papers on mechanism of resistance, pharmacology of antimicrobial agents, epidemiology and clinical therapeutics, and others. We have also several sections that would you very enjoy if you want to learn from how to treat a patient with a difficult to treat infection to antibiotic stewardship. I'm also making a new announcement because this is very exciting. Because after many years, both the American Society for Microbiology and the Infectious Disease Society of America have joined forces to launch a new meeting in antimicrobial resistance, which is going to happen in January of 2026, the first chapter, and reviving this whole feeling that we had before with another meeting and put all the stakeholders together in the same ecosystem with the science of antimicrobial resistance and the clinical applicability of this. So mark your calendar for January 28th to the 30th in Las Vegas, Nevada, for the new meeting that is going to be called IMARI, International Meeting of Antimicrobial Resistance and Innovation. So joining me in this exciting episode is a real legend here in Houston on infectious diseases. It's Dr. Daniel Musher, who is a distinguished service professor of medicine and infectious diseases at Baylor College of Medicine. He's also professor of microbiology and molecular biology at Baylor College of Medicine here in Houston, Texas. And he's been in the Michael DeBakey Veterinary Affairs Center for many years and has a tremendous and incredible experience in this topic. So, Dr. Musher, is really an honor and welcome to the show.
Thank you for your nice introduction, and I'm very excited to hear that ASM and IDSA are getting back together for a meeting. Historically,
Yes,
we always had meetings together, and then they divorced about 15 years ago. I'm delighted that they'll be back together.
Yes, we are very excited about this new partnership, and as it should be, in a topic that brings all the issues from basic science to clinical practice. So, Dr. Musher, so how many years have you been working on aspects related to pneumonia and respiratory infections?
Well, Dr. Arias, I'm an old man, so I've been practicing. I came on the faculty 53 years ago, almost 54 years ago, and I began working on the immunology of syphilis, believe it or not. But I soon became interested in pneumonia because that's what we were seeing on the consult service. In those days, the textbook chapter on pneumonia was the same as the textbook chapter on pneumococcus. And I was taught that all pneumonia was due to pneumococcus, except for that due to so-called atypical agents, which were Mycoplasma pneumoniae. And I remember as a fellow asking the famous Dr. Robert Austrian, are all those pneumonias really caused by pneumococcus? And he kind of patted me on the head in a condescending sort of way and said, yes, Dan, they are.
That's a wonderful story. This is like, real history of this. So what if you could think about the highlights of the changes that you've experienced on this syndrome throughout the years, what would you highlight?
Okay, well, first I would say that the recognition using classical techniques of other bacterial agents has been greatly expanded. And I have to say, I contributed to that expansion. It began with my work on Haemophilus. See, Dr. Arias, I was just seeing patients. I mean, I love infectious diseases. I do not make any separation or distinction between so-called research and so-called clinical medicine. It's all the same. And if I would see things, I'd make observations. So I would look at the gram stains of expectorated sputum in patients with pneumonia, and I was seeing a lot of gram stains showing fine little gram-negative coccobacilli, cultures yielding Haemophilus influenzae, and that was being recorded as commensal organisms, unless they were typable. And of course, that didn't make any sense. So I started to study Haemophilus influenzae pneumonia. I showed that the organism causes a substantial amount of community-acquired pneumonia. I had to show that the patients who were infected with this organism had rising antibody that was both bactericidal and opsonophagocytic. And I added Haemophilus influenzae to the list. Gram-negative pneumonias were thought to be exceedingly rare. There was a report by Dr. Lerner, maybe in the Annals of Internal Medicine in early 1970s. He reported maybe 8 or 10 cases, and that was considered important enough to make a report, which is kind of surprising. But that was the status then. To the importance of pneumococcus and Haemophilus was added Moraxella. This is in community-acquired pneumonia. And I also studied Staph aureus. And in 1976, in a paper on Staph aureus pneumonias that led to hospitalization with consultation to an ID service, I showed a large series of staphylococcal pneumonias and almost as large a, I think it was the largest series of staph pneumonias ever reported. It was just part of another paper. So now the spectrum was pneumococcus, Haemophilus, Moraxella, and Staph aureus. And gram-negative rods were hovering in the background with the increased numbers of patients with immune-compromised states as a result of just plain aging and debility, and then steroid use, and more recently, immunosuppressive agents. Gram-negative rods played an increasingly important role. So the landscape of bacterial causes of pneumonia consistently evolved during my career in infectious diseases over these last few decades.
Dr. Musher, uh, just as a corollary of that beautiful description, this terminology, of community acquired initially, now we call it associated. and then healthcare associated or community onset, and there is like a soup of terminology there. Um, I mean, with good reasons for people. So, but with the advancement of medicine and everything we are doing to our patients, I think there is a blurry line on this. And people used to teach us you have to treat this in this way, this in that way. How do you see those changes in this classification that the guidelines love to put there?
Dr. Arias, I love the question. Let's start with the terminology. I wrote a paper, a review paper in New England Journal of Medicine. It's probably about 9 or 10 years ago with Dr. Anna Thorner. And I used the phrase community acquired pneumonia exactly once in the opening section, put it in quotes. I don't like the term. I just don't like it because I don't think it's very relevant. Everybody uses CAP. They like the abbreviation. They use it. For me, it's pneumonia. So I totally agree with your question. Now, people who are perfectly normal in health, they're just out there running around in the community, sometimes get pneumonia. It was a much more common disease in the pre-antibiotic era, far more common. And among people as they age, it increases in incidence substantially. But the picture of it changes if they have been in a hospital, in and out of a hospital, received antibiotics, received steroids. So it is a very mixed picture. I do agree with you. And I'm not crazy about the term community acquired pneumonia or CAP. I try to avoid using it.
Great. And the other terminology that people have used for a long time is this thing called atypicals, atypical organisms. So, what is your opinion about that terminology of atypical organism when we now know they are probably more typical than atypical?
In that same review article that I just mentioned, I also used the word atypical, I think once, putting it in quotes and stating that I didn't like it. The history of it is that in the late 1930s, when all pneumonia was thought to be caused by pneumococcus, there were some pneumonias that were leading to hospitalization, just a small number, in which a gram stain and a culture didn't show an organism. And later on, when penicillin came along, they weren't treatable with uh, penicillin. So they didn't know what the organism was. They couldn't see it by gram stain because it doesn't stain, doesn't have a typical cell wall. And they called them atypical pneumonia. The term now is used to describe a family of organisms, mycoplasma, chlamydia, Coxiella burnetii, of which I saw a lot. It's Q fever, I saw a lot when I was stationed with the military in Laredo, Texas. But I don't like the term. It really is. It's pneumonia, which a gram stain's negative, and it can make you very sick. And Legionella, excuse me, is another one, and they lump that together. Legionella is a nasty bacteria, makes people terribly sick. Most mycoplasma pneumonia cases do not lead to hospitalization, and the peak age of mycoplasma pneumoniae infection actually is kids 8 to 10 or 12 years old. So the whole thing, it's just bad terminology. And my grandfather, who was a very well known philosopher and rabbi, said that the words we use influence our thinking. So that he didn't use feedback because that concept wasn't known, but it's true. You use the wrong word, it makes you think incorrectly. So I think precision of words makes a big difference. And I love your questions.
Yeah, I couldn't agree more. So that's what I tell. I'm on service right now. Tell my resident and my fellow that I don't want to hear the word cover in my service
Oh,
because completely
absolutely.
undermine my train of thought. So I either
Absolutely.
treat empirically or treat definitely, but I never cover anything.
Yeah, except with a blanket. Couldn't agree more.
So, based on that, I think if you look at w- one of the things that have evolved mm, a lot in pneumonia is what we call uh, the rapid diagnostics and our ability of make more precise diagnosis. I love always your talks, and when you go and help us understand and go and see the gram stain, which is still so important, and but people are doing this less and less for many reasons, that is mainly a pressure in this system in this country. But definitely rapid diagnostics is something that has emerged, that has, I would say, benefits and also pitfalls. So, what are your thoughts on this new diagnosis and the ability to make diagnosis of things that we couldn't do before?
With your permission, may I begin by talking about classical techniques, gram stain and culture first, and then I will come to the more
Absolutely.
update. So, uh, a few years ago, I did publish a study in which I included only patients who produced a good purulent specimen of sputum. What we cough up is, of course, the material that's accumulating in the alveoli, and that's what pneumonia is, material collecting in the alveoli. We cough that up, and if you have a good specimen, it should show you exactly what's in the lungs. So, using quantitative microbiology and gram stain on patients who provided a good purulent sputum, I was able to reach a correct bacteriologic diagnosis in a very substantial percentage. And what's been reported before by me, as well as by the CDC and by others, has been only about a 50% rate of making a proper diagnosis. So I do want to say that the gram stain and the culture of a properly obtained specimen are exceedingly likely to yield a correct bacteriologic diagnosis. If no bacteria are seen, or if large numbers of bacteria, I shouldn't say no, it should be large numbers of bacteria. There should be, in general, several bacteria for every white blood cell. If you do quantitative studies, that's what you'll find. So if there aren't lots of bacteria, it's almost certainly not a bacterial pneumonia. And that's exactly why I object to the concept of the patient being, quote, covered with antibiotics just blindly when there's no bacterial disease at all. And I think we would all agree antibiotics don't do much for viruses. So anyhow, the newer techniques include PCR technology for being used directly on sputum. And I was fortunate enough to work with one of the women who developed PCR technology, and we studied specimens that I obtained, and I shipped them to her in Scotland. And we found that the PCR technology had lots of false positives, although it didn't miss organisms that were causing bacterial pneumonia. So it would identify a Staph aureus or a pneumococcus or a Haemophilus when I identified them by these classical techniques, but it also identified them in lots of other specimens where these organisms weren't present in sufficient numbers to really be implicated in pneumonia. So the PCR technology uh, does report lots of false positives, but I don't think it misses very much. And there's been an increasing use of PCR technology. I was also able to study a very small series of patients using what's called the Carius test. Uh, Dr. Arias, what's the proper name of that technology? for a
Yeah.
carrier.
So the microbial cell-free DNA, right?
Yeah, that's exactly. Thank you. I always stumble on that one. Please excuse me. And so I submitted plasma on patients whom I had studied very carefully, serum plasma, and these patients unquestionably had pneumonia. And the Carius test gave false negatives in several, gave false positives in several, and gave true positives in several. And the company limited me to a small number of samples. But I don't think that's a good way to diagnose pneumonia. I think, again, if patients are, I think physicians, when I wrote the chapter in the Harrison's textbook on pneumonia, I said it's the obligation of the physician to obtain a good specimen. And unfortunately, the way it's done is the doctors write, get sputum specimen, and they walk away from the bedside and they leave a cup by the bedside. They don't, excuse me. The nurses walk in and put a cup by the bedside. And we know perfectly well when we're making rounds the next day and the patient's already gotten antibiotics for 24 hours, there's the cup sitting there. I've shown that after 24 hours of antibiotics, there's no point in sending a specimen for culture because you're going to miss it 80% of the time. So either you get a good specimen and treat the patient properly, or you're treating blindly. I don't even like that term empirically. Empiric sounds fancy. You don't know what you're doing. And I think we as physicians are obligated to do everything we can to try to find a proper cause. So anyway, the traditional microbiologic techniques, if a patient provides a good specimen, are awfully good. The PCR, if the patient provides an awfully good specimen, will give you some false positives. And I think if you provide a poor specimen, it'll give you even more false positives.
So and what are your thoughts about the this sometimes the diagnosis of pneumonia is tricky for many reasons. And of course, you get one of these tests and you get an organism that you are not sure if it's a colonizer of the airway or is a true pathogen, which I think is one of the important limitations of this test. So, what are your thoughts on those scenarios?
Oh, okay, Dr. Arias, you make a wonderful point, which I had skipped over. Uh, 12 years ago, I set up a study. It's just at my hospital, but that meant it was a single center study. People don't like those. I like it if it's at my hospital because I'm doing it and I can control exactly what is done. We studied every single patient who was admitted from the emergency room during exactly a 12-month period. Now, the only patients we didn't study are ones who refused to sign a consent form. And at the VA, patients tend to be very cooperative, and I think I was pretty nice, and my research assistant was pretty nice, and almost all the patients we asked consented. And I think we began with something like 249 patients who were admitted with a diagnosis of, quote, community-acquired pneumonia, which I've already said I'm not crazy about, but that's what they were admitted with. And when we analyzed the data and looked over the whole thing, it turned out that I think 17% of them didn't have pneumonia at all. They had heart failure, and there were some who had interstitial lung disease and a variety of things. So they didn't even have pneumonia. Now, what PCR has added is the ability to detect viruses. This is tremendously important because we couldn't do that before. So you can use a nasopharyngeal swab and find evidence for respiratory viruses. And we presume, and I think it's a pretty good presumption, that if you get a positive PCR on a nasopharyngeal specimen for a respiratory virus and the patient's got pneumonia, that's the cause of pneumonia. In the CDC study, which was very similar to that one that I mentioned, in which I did all those patients admitted to the hospital, I did it in just my hospital. The CDC did almost an identical study in 8 hospitals, and I had a higher diagnostic yield, but not awfully much higher. But what they did is they did control patients as well, meaning hospitalized patients who did not have pneumonia. And they found positive nasopharyngeal swab for respiratory virus in about 2%. So what that means is that if you find in patients admitted with pneumonia, you find evidence for a respiratory virus in 20-25%, that's telling you that the virus is implicated as a cause of pneumonia in a substantial proportion of patients. And that has been an important addition to our technology using PCR for viruses.
Yeah, and the other one I want you to comment. The other thing I want you to comment is the co-infections, because sometimes now that we have the ability to diagnose viruses, then we find them with bacteria, and which one is the one causing the problem? Are they both? We go into the Occam razor that maybe this not explains that, but we know that now there are microbial interactions that benefit both organisms in order to survive, and this is evolution. So, what are your thoughts about these co-infections?
Okay, first, let me emphasize, and again, your point is extremely well made. In that most recent study, the one that was confined to patients who could provide a valid sputum specimen, so I could tell definitively if they had bacterial infection or not, I should mention that 20% were found to have a respiratory virus, and I think, gosh, I don't remember the actual numbers, but I think that about 30% had a respiratory virus. 15% had just the virus is found, and the others were co-infected. That means we found a bacterial possible cause and a viral possible cause. So co-infection is very, very important. And one of the questions addressed by the guidelines committee for the combined American Thoracic Society and the Infectious Disease Society was, what should you do as far as empiric treatment if a patient has a positive viral PCR? Because you get that on everybody. It's easy to do. Doing the nasopharyngeal swab, you get a virus, or don't get a virus, but you've got a valid specimen. If you don't get a good sputum specimen, you can't exclude a bacterial pneumonia. So even if the viral PCR is positive, if you don't have a good sputum specimen, I think those patients should be treated conventionally with the recommended empiric therapy, which is as if they did have a bacterial pneumonia. You can't well enough distinguish the bacterial from the viral ones. And the viral ones have a good chance of having a bacterial co-infection. So it's a terribly important point.
Fantastic. So let's move on treatment, on therapeutics, that you just started to mention something about this. In all these 50 plus years that you've seen all kind of antibiotics, what what are important things that you can tell us about the treatment approach for pneumonia? What has changed,
Okay.
or what has not changed, or what are your
Well,
thoughts on that?
how about if I'll avoid the history because I'll bore everybody to death. But I will say that most of the time, unless a patient is substantially immune compromised, or unless a patient has recently been in a hospital, and in that case, he or she will have been exposed to some array of new bacteria or may very well have received a course of antibiotics, him or herself. Except for those, I think that we tend to select an antibiotic that's effective against the most common organisms. The most common organisms remain pneumococcus and Haemophilus. At the present time, they are equally common, Dr. Arias. Pneumococcus is no longer the predominant organism, and that's a result of the vaccination of little kids who don't carry the organism, don't infect their older adults in the family. So we pick an antibiotic that's effective against pneumococcus, Haemophilus, and Moraxella. And the antibiotic that we use now that there's a little bit MRSA in the community, a lot less MRSA in the community than there was 20 years ago, that drug is effective against most of the bacterial pathogens that will cause pneumonia in an ordinary person who's out there in the community. And that drug that is preferred in the United States is something like ceftriaxone. Ampicillin sulbactam is just as effective. In Europe, where they have Haemophilus that tends to be ampicillin or penicillin susceptible, it doesn't make a beta-lactamase. There are some countries that even just recommend penicillin. But they don't have a high rate of penicillin-resistant Haemophilus, ampicillin-resistant Haemophilus. I'm always surprised because I'm sure they have a substantial rate of penicillinase-producing Staph aureus, but that's not a terribly common cause of pneumonia. Now, in the United States as well, the guidelines recommend the addition of a macrolide or a tetracycline or the use of a quinolone. And you can argue that that's questionable. If you look at the CDC data from their study, you'll find that in total, 3 or 4% of all patients admitted to the hospital, this is hospitalized patients, only 3 or 4% have pneumonia due to mycoplasma or Legionella, which are the really ones that need to be, or chlamydia. Those are the ones that need to be treated. It's a very small percentage, but we routinely add this other drug. Now, we rationalize it by saying that especially the macrolides are well known to suppress the inflammatory response. And the macrolides may be helpful at treating pneumonia just because the disease itself is inflammation. It's inflammatory material collecting in the lungs. That's what is pneumonia. So if you suppress inflammation somewhat and kill off the bacteria at the same time with the other antibiotic you're giving, that's advantageous. So the guidelines recommend an antibiotic effective against bacteria that have typical cell walls and commonly cause pneumonia, which, as I said, is a third-generation cephalosporin. Ceftriaxone is the easiest to administer, or ampicillin sulbactam is a good example, and together with a macrolide. But as I said, you could probably do just as well with the beta-lactam alone. Could I also mention that the studies that I didn't mention this, the studies that I did showed that what's called so-called normal respiratory flora or commensal bacteria actually cause about 20% of so-called community-acquired pneumonia. And you can only show that by doing quantitative bacteriology on patients who provide really good sputum samples and comparing it with gram stain results. And again, the quantitative bacteriology compares extremely well with the gram stain results if you've got a good specimen. So those would be ignored by the laboratory. And if you decided you weren't going to treat a patient uh, just because he had a positive PCR for respiratory virus. If you weren't going to treat him, even if you had a sputum culture and it shows normal respiratory flora, and even if it were a valid specimen, you might be making a mistake. That's the problem. And you have to look at the gram stain. The labs don't do that. They don't identify normal respiratory flora. I mean, they don't identify them as a cause of pneumonia. They don't speciate them. They just write normal respiratory flora. That's what their protocol says to do.
Beautiful. This is so insightful. So, a simple question, also in treatment, that I think is a very hot topic. So, how long should you treat a pneumonia?
Oh, that's a question that the guidelines committee really agonized over. There was a study during the Korean War in which a single injection of procaine penicillin cured pneumococcal pneumonia. In those days, the minimal inhibitory concentration of penicillin for pneumococcus was 0.06 micrograms per mil, and a single dose of procaine penicillin kept the level above that for at least 24 hours. 24 hours treatment. These were otherwise healthy young adults. They'd been stressed out. They were crowded conditions. They got pneumococcal pneumonia, cured them with a single dose. Uh, People started to treat longer and longer and longer intervals with no evidence that it was needed. So by the time I was junior faculty, the recommendations were 10 to 14 days, 7 to 14 days. My son, who's an oncologist, kids me. He says, "You infectious disease doctors think that bacteria carry calendars. And you recommend 7 days or something, or 10 days or 14 days." Anyway, that's a digression, sorry. But um, 7 days is longer than is needed to treat most organisms that cause pneumonia. Uh, I'd like to exclude from consideration organisms like pneumococcus and gram-negative organisms just for a moment. And the reason is that pneumococcus may be causing microabscesses, and gram-negative organisms, when they cause pneumonia, cause a venulitis, and they can be destructive. And I think if there's destruction in the lungs or there's abscess, microabscess formation, slightly longer treatment is appropriate. See, that's the problem. They all get lumped together under this category that you and I don't like, community-acquired pneumonia. And I think that they should be identified based on what the cause is. That was the point of that article in New England Journal of Medicine. I didn't like community-acquired as an adjective modifying the word pneumonia. I felt it should be staphylococcal, pneumococcal, Haemophilus, gram-negative, but it shouldn't be community-acquired. That's not a definition of an organism. At any rate, the data show that 5 days of treatment really should suffice. The guidelines committee then started to try to shorten it. And the consensus, in fact, was to recommend only 3 days. Pardon my use of the word only. They recommended 3 days of antibiotic treatment to treat community-acquired pneumonia. I was one of the outliers on the committee. I still think that 4 or 5 days of treatment should be given to treat pneumonia due to the pneumococcus, Haemophilus, Moraxella group, and Staph aureus if the patient is not terribly sick. And I studied it. I'm the one who shows how rapidly those organisms go away. They're gone from the sputum. Pneumococci are gone from the sputum by 24 hours in most cases of a drug. So you could say that maybe if the host is in reasonable condition and the bacteria are largely gone in 24 hours, maybe 1 or 2 days does suffice. I still prefer 4 or 5 days, but longer than that is just not necessary, except perhaps for Staph aureus or gram-negative rod pneumonia.
Okay, yeah, absolutely. This is so important. So, let's imagine that you have now all the money in the world to do a trial in pneumonia now in April of the 2025. So what trial do you think is one of the most relevant trials that we should be doing now in terms of learning how to treat pneumonia right now?
Oh, you ask a difficult question. First, I'm going to get by kidding around with you. You don't want to start your trial in April because the seasonal incidence of pneumonia, the pneumonia season kind of begins in October and runs through March. So don't begin your trial in April or May. Don't do it.
Point well taken.
You'll sit around and wait for the patients to come in. I think that a good study on the duration of antibiotics would be helpful because we really did not have good data to look at the committee. There were no good prospective studies of 3 versus 4 versus 5 days. They studied macrolides, but macrolides have a half-life of 24 hours, 48 hours. I mean, they hang around a long time, so that doesn't compare with beta-lactam, which is a half-life of an hour, 40 minutes, depends, 20 minutes, depends which drug it is you're choosing. I think it'd be interesting to study the duration of treatment. Uh, I think that the use of oral treatment after the after if a patient's got severe enough pneumonia to be hospitalized after first dose or two, which you want to give antibiotics parenterally, I think it should all be oral. All should be oral treatment. Now, why do I say that? When a patient's sick enough to be admitted to the hospital, technically speaking, you don't know if he or she's going to go into shock in the next 6 or 12 hours. You want to be sure that first dose of antibiotic is given, is absorbed, gets into the bloodstream, and goes to the lungs. And that's the advantage of that first dose being given IV. And after the patient's condition is stabilized and it's clear that they haven't gone into shock, then I think it should all be oral treatment. I don't even think that needs a study, but there are some people who think that needs a study because they're wedded to intravenous antibiotics. That sounds so good. I'm going to put the patient in the hospital and give him intravenous antibiotics. And that impresses the patient and the doctor feels good, but that's sort of nonsense. So I think that's one thing that's important to study. The other is this role of viruses and bacteria, but I think you're going to end up treating them with antibiotics anyway, and that's because 20% of those pneumonias at least are caused by so-called normal respiratory flora, and you can't do the kinds of studies that I did on a small number of patients. I mean, I studied 120, 130 patients. You can't do those in a routine diagnostic lab, and nobody's going to. Other questions, of course, as other viruses are identified by PCR, they have to be treated as well, don't they? So if you find influenza virus, which we didn't find much of because the VA patients are a highly vaccinated population, I'm pleased to say. So my study at my hospital showed a tiny percent of influenza pneumonias. The CDC study showed 6 or 7% of patients had influenza pneumonia. And if other antivirals come along, Dr. Arias, you'll want to be able to treat those as well. So the PCR will be helpful. But as of right now, I mean, look, we went through that with COVID. But as of right now, the next virus down on the list is the parainfluenza and human metapneumovirus, for which is adenovirus. And at present, there's no treatment for those. So I don't think it matters. I'm not sure I answered. Did I answer your question?
Yes, absolutely. Yes, that's very important insights and caveats. So I'm going to give you now to close the crystal ball. So what would you predict pneumonia will be treated in 10 years, 15 years from now? what is going to change, or are we still will be struggling with the same questions that if we were to do this podcast in 20 years, um, probably we won't be around, but if somebody will do it, so we'll be asking the same questions and having the same issues. uh,
Okay.
what are
In,
your thoughts on that?
in 10 or 20 years, you'll be around, I won't. But I think we're still not going to have precise enough techniques to tell exactly what is the cause of pneumonia. So I think these same discussions are going to go on. I really do. I'd like to assure a listening audience that it's all going to be solved, wrapped up neatly, and you'll know exactly how to treat. But I've been in this business a long time, and nobody has yet known. And people have said, well, we're going to find out. Now we have a this, now we have a that, now we've got a PCR, now we can detect DNA in the serum. We're going to have answers. We haven't had them yet. I don't think we're going to. So I think the discussions are going to go on.
Beautiful. Well, I want to thank you, Dr. Musher, for this beautiful, insightful, and futuristic conversation. It's been wonderful to learn from you, as I do every day. And it's a privilege to have you just around here to answer all these questions. And I wanted to transmit that to all our audience. So thank you very much for being part of the show. So this is Cesar Arias, editor in chief of AAC, signing off.